Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA. My name is Isabel Olivera and I'm a medical writer for the EHA. I have the pleasure to have here with me today Professor Helen Papadaki. Welcome, Professor Papadaki. Can you please introduce yourself?
Thank you. Thank you for inviting me. I'm Helen Papadaki and I'm Professor of Hematology in the University of Crete in Greece. My specific focus is neutropenias, and I'm treating every kind of neutropenia patient, however.
Thank you. So we are going to discuss today what is clonal hematopoiesis and how its identification has an impact on the follow-up of patients with unexplained cytopenias, and particularly neutropenias.
Well, let's start with a definition. What is clonal hematopoiesis? This is a general term to describe the situation where a distinct hematopoietic cell or progenitor cell population with some genetic abnormalities give rise to progeny that can be detected in the peripheral blood, usually by NGS, by next generation sequencing. And they carry the acquired variant that the stem cell population has also. So this is clonal hematopoiesis. This is the general term. However, we have another term, the term CHIP, which is clonal hematopoiesis of indeterminate significant potential. That is actually the situation where clonal hematopoiesis present in an individual with no other abnormalities, with no any hematologic disease, no neutropenia, no dysplasia, and usually it concerns genes that are related to myeloid malignancies. So this is CHIP, and if the patient has clonal hematopoiesis and any kind of cytopenia, then we use the term CCUS, which is clonal cytopenia of undetermined significance. So we have CHIP, the term CHIP, when the individual has clonal hematopoiesis, but no cytopenia, no hematologic disorder, no dysplasia. And we have the term CCUS, clonal hematopoiesis, when the individual has a kind of cytopenia. So
this is the difference between CHIP and CCUS.
Yes, so
CCUS?
we have CHIP when the individual has no cytopenia, and CCUS when the individual has cytopenia. Both cases have clonal hematopoiesis in genes related to a myeloid malignancy. And in the clinical practice that you asked in the beginning, it's very important to distinguish those patients that have cytopenia and clonal hematopoiesis, because it has been shown that those patients with cytopenia and clonal hematopoiesis have increased risk to develop myelodysplastic syndrome or acute myeloid leukemia compared to those patients who has just cytopenia without clonal hematopoiesis. And for these patients, we use another term, which is ICUS. So it is idiopathic cytopenia of undetermined significance. So in case that we have a patient with cytopenia, if she has clonal hematopoiesis, we call the disorder CCUS. But if the cytopenic patient has no clonal hematopoiesis, we use the term ICUS, idiopathic cytopenia of undetermined significance. So these are the terms that have been introduced in the clinical practice. And as I said before, it's very important to distinguish these cases. According to our experience, in a cohort of patients with neutropenia, with unexplained neutropenias, what we call the idiopathic neutropenia, we have found that if you examine this cohort of patients without knowing if they have clonal hematopoiesis or not. So if you examine this cohort of patients, they have a risk to develop leukemia, a low risk, 2.7% develop leukemia. However, those patients with neutropenia and clonal hematopoiesis have a 30-fold increased probability to develop leukemia compared to those patients with neutropenia and no clonal hematopoiesis.
So it's essential to
yes,
discriminate
so
whether you have cytopenia with or without clonal hematopoiesis.
And this is the reason that in the recently published guidelines how we investigate neutropenias, we have recommended that those patients that are characterized, I always refer to adults, those patients with unexplained neutropenias, for those patients it is necessary to perform the NGS panel with those genes that are related to myeloid malignancies. Of course, however, this is the probability depends on many parameters, however. It's not only the clonal hematopoiesis, but it is the size of the clone. For example, if you have a clone more than 10%, the variant allele frequency of more than 10%, then the probability is even higher. It depends on the type of mutation. For example, there are mutations that mostly related to the age. For example, it is DNMT3, SXL1, T2. These mutations are mostly related with age. However, if you have this mutation combined with others, the risk increases. And also if you have mutations in genes related to RNA splicing or, for example, IDH1 or IDH2, TP53. So it depends on if you have clonal hematopoiesis, the probability to develop acute leukemia or myelodysplastic syndrome depends on the type of mutation, the number of mutation, and the combination of mutations that you probably have.
So you have to really identify the specific mutations. It means that you always have to do NGS sequencing when you detect that there is clonal hematopoiesis? Or how do you detect first that there is clonal hematopoiesis?
Well, when you investigate a patient, an adult patient with neutropenia, you have to perform an extended laboratory investigation to exclude, for example, autoimmune disease, hematologic diseases, etc. So to exclude any type of disease that may result in neutropenia. But if you finally do not identify any underlying disease, in such case you have what you call idiopathic neutropenia. In such cases, we have recommended to perform this NGL panel that comprises a number of genes that are related to myeloid malignancies. So, and if you identify a mutation, then you call this patient CCUS, clonal.
Yes.
Patient with clonal hematopoiesis.
Clonal and cytopenia of undetermined significance.
So, yes, and it is important to identify such cases because, as I said before, these patients have increased probability to develop leukemia. And then, if you know that the patient has clonal hematopoiesis, then you have to have a more close follow-up. Of course, there is no need to perform very frequently NGS analysis. It's not easy, it's expensive, etc. It is adequate to perform just a close follow-up with the blood counts and see if the patient remains stable, if the neutropenia is worsened, if he or she develops other types of cytopenias. But in general, this patient has to have a more close follow-up compared to a patient without clonal hematopoiesis.
And you spoke that you can have clonal hematopoiesis without cytopenia.
Mm-hmm.
How do you detect these patients that have clonal hematopoiesis? Why would you test?
This is actually a very interesting question. There were some big studies in approximately 2014, big studies in the general population, and they have found it was a research And it was found that in the general population, there are individuals, because they are not patients, there are individuals with clonal hematopoiesis, and it has been shown that clonal hematopoiesis in the general population relates to the age. For example, clonal hematopoiesis is identified in approximately 10% over 70 years and approximately 20% in individuals of over 90 years. And when you have clonal hematopoiesis, you may have increased risk to develop hematologic disease, a hematologic malignancy. The risk is tenfold higher than the general population, and it is 0.5 to 1% per year to develop the risk to develop myeloid malignancy. And on the other hand, it was very interesting the fact that these patients with clonal hematopoiesis have also, these individuals with clonal hematopoiesis have also increased risk to develop cardiovascular diseases. So it was an interesting study in the general population that was first described this clonal hematopoiesis, and after that it was incorporated, included in the clinical practice.
So as you said, these people that have clonal hematopoiesis, are not patients.
Yes, they are not patients.
So they will, in this case, in this study, they were tested specifically.
Yes, it was a research study.
But normally, people would not know they have clonal hematopoiesis. It's just a matter of...
Yes.
It's not tested in any case.
Yes,
because testing would require NGS sequencing.
Yes, exactly. Which, of course, it's something expensive, and there is no reason to perform such studies in the general population.
And it would create people who know they have a predisposition for cancer. So it would create ethical questions whether to inform these people that they have an increased risk of cancer or not. And
exactly.
So it's not something that is done at the moment, trying to see if you have clonal hematopoiesis if you don't have cytopenias.
Yes,
it's something that doesn't happen.
Yes, but it is highly recommended in patients with cytopenias, with unexplained cytopenias.
So people will learn that they have clonal hematopoiesis in general already when they have cytopenias of some kind. That's their starting point. And then they will have to have a follow-up of every 6 months, every year. What is the follow-up?
Actually, when we have a patient with mild neutropenia without clonal hematopoiesis, we usually perform blood test every 6 months. But if we have clonal hematopoiesis, we recommend to have this test at least 4 times a year. But it always depends on the severity of neutropenia, of the cytopenia, and also from the clinical manifestations. For example, if you have a patient with neutropenia and infections, you have to see him here more frequently. But in general, if you have the patient with cytopenia and clonal hematopoiesis, you have to perform close follow-up at least 4 times a year. But as I said before, there is no necessary to perform NGS analysis in every visit. It's enough to perform just to examine just the blood counts.
And will you manage differently a patient that has clonal hematopoiesis with cytopenia, or just have cytopenia without clonal hematopoiesis?
No, we treat them in the same way, but we just have a more close follow-up in the patients with clonal hematopoiesis. However, if they do not need treatment, GCSF, for example, for the neutropenic patient, we do not give GCSF unless, depending on just for the blood counts, but it depends on the clinical manifestations. If you have a patient with infections, then you treat the patient regardless the presence of clonal hematopoiesis or not.
Could you also explain how to discriminate between somatic and germline mutations?
Yeah, that's interesting because sometimes you identify mutations that you do not know that they are actually somatic, and you have to be sure that they are somatic mutation. You suspect that you may have germline mutation if the clone is very high, more than 50%. However, you may also perform, you can also perform some NGS analysis from specific specimens, for example, from the buccal, with buccal swab, or with hair follicle keratinocytes, or from fibroblasts from the skin. So if you identify the mutation there, then it is a germline mutation.
And so in patients with congenital neutropenia, why is it particularly important to identify clonal hematopoiesis?
Yeah, before we discussed about patients with idiopathic cytopenias, which means that they do not have a congenital background, they have an acquired disorder, and you just identify clonal hematopoiesis and they need a close follow-up. However, patients with congenital neutropenias, this is another entity, because some of these patients have an increased propensity to develop acute leukemia regardless the presence of clonal hematopoiesis. So in these congenital neutropenia patients, if you identify clonal hematopoiesis, then there is a higher risk to develop probably leukemia. But again, it depends on the type of clonal disease, clonal hematopoiesis, the type of mutation that you identify. For example, mutations related to GCSF receptor, RANX1 mutations of TP53, they are considered as high-risk mutation. So particularly in patients with congenital neutropenias, the identification of clonal hematopoiesis is an additional risk for the development of acute myeloid leukemia. So it's very important to perform this analysis at least once a year.
And these patients with congenital neutropenia, are they younger?
Yes. Usually congenital neutropenias are severe neutropenias, and they are diagnosed very early in life. So this is actually under the follow-up of pediatrician hematologists. And they usually are identified early in life.
And they have to have a follow-up,
Yes.
close follow-up during all their lives.
Yes.
What do you find more fascinating about this phenomenon of clonal hematopoiesis that has been discovered these last years?
Actually, it's a fascinating area of research. Of course, it has a great significance in the clinical practice, but in the research field, we're very interested to have a follow-up on the clonal evolution, if there is. So we have, but this is just for research, not for the clinic. So we have a follow-up in these patients, not only by having the follow-up on their blood count, but we also examine the clone. And in those patients that develop acute myeloid leukemia or myelodysplastic syndrome, it's very interesting to see that just before the myeloid evolution, they increase the clone or they acquire additional clones. So it's very interesting to have this follow-up of the patients, but also to have the follow-up of the clone to see what happens there and how it is related to the clonal evolution. But on the other hand, it's very interesting to identify what is the link between clonal hematopoiesis and cardiovascular disorder, because as I said before, in the general population, if you identify a clonal hematopoiesis in a patient that is already over 70, and the rate of evolution is 0.5 to 1%, then the probability to develop acute leukemia is not as high. However, these this individual have increased risk for cardiovascular disorder. And this is very important. And there are some clinics in some big hospitals that have developed an outpatient clinic that give guidance to those individuals with clonal hematopoiesis how not to develop cardiovascular disease. So it's very interesting to see how clonal hematopoiesis is related to cardiovascular disorders.
Is it known, the mechanism, by which clonal hematopoiesis leads to an increased risk of
There is a hypothesis that
the
clonal cells produce more inflammatory cytokines, and these inflammatory cytokines are related to the cardiovascular disease because of the damage of the endothelial cells, etc. So it's very interesting.
So this is also a field where research is ongoing and is very active at the moment.
Exactly.
If you want to summarize for a general hematologist, when to decide to send a patient to detect whether they have clonal hematopoiesis or not?
Yeah. In the outpatient clinic, it's very frequent to have individuals, patients that come for unexplained cytopenias, anemia, thrombocytopenia, or neutropenia. So when you exclude any underlying diseases, disorders, autoimmune, etc., and you have these patients that are called idiopathic cases, anemic, neutropenic, or thrombocytopenic patients without an underlying disease. So for these idiopathic cases, we should perform a clonal amyloid panel and perform the NGS analysis to identify clonal hematopoiesis. So for these patients with unexplained cytopenias, it is necessary to perform the myeloid panel, the NGS panel, and for these patients, we need then a more close follow-up in order to identify those patients that have higher probability to develop myelodysplastic syndromes or acute myeloid leukemia.
Is there anything else that you would like to add for our audience?
I think that it would be it would be nice to, and very important and very useful for the hematologists in different countries to have this tool. It's not available everywhere because NGS analysis is something expensive, and although it is highly recommended, it's not available in all countries. So this is a problem, and this is something that we have to see at a higher level, how to facilitate this test to be performed more widely.
Could it be an option to perform the test in the countries that have this facility for the countries that do not have them?
It's something that should be discussed, in networks, etc.
In networks, yes, because it's not a lot of patients that we're talking about. Or
there are a lot of patients.
There are a lot of patients.
Yes.
So it would be interesting to develop the facility in each country.
Exactly.
Thank you for this very enlightening discussion. Thank you, Professor Papadaki, for sharing your expertise with us, and to all of you for listening.
Thank you very much for giving me this opportunity to share these options. Thank you very much.